Imagine for a second um, the single greatest challenge in clinical medicine. I mean, most people would probably picture curing some incredibly rare, obscure disease, or maybe a surgeon doing this, wildly intricate neurosurgery.
Right, something very dramatic.
Yeah, exactly. But it's actually much more fundamental than that. The greatest, most persistent challenge is just managing human pain.
It really is, because pain isn't just, a simple binary switch that you can flip off. It's highly subjective. It's this really complex consequence of neurochemical processes happening in both your peripheral nerves and your central nervous system.
And it's invisible, right? Like,
Yeah.
you can't measure pain on a blood test.
Exactly. You can't see it on an X-ray. As a physician, you have to rely entirely on the patient's perception and, well, their description of what they're feeling in that exact moment.
And when that pain crosses the line from mild to severe, whether it's from a traumatic injury, a major surgery, or a disease like cancer, medicine brings out the heavy artillery.
The big gun.
Right. So today's deep dive explores a pretty dense stack of pharmacology texts, unpacking the fascinating double-edged sword of opioids. I mean, we hear about them constantly in the news, usually regarding the addiction crisis, but we're going to look under the hood today.
We really need to understand the mechanics.
Yeah, we're going to figure out exactly how these molecules work inside your body, why they're so incredibly effective at stopping agony, and why that exact same mechanism makes them so uniquely dangerous.
To really grasp that danger, we have to look at the cellular level. But before we even look at the drugs themselves, we need to talk about the body's natural pain management system, because opioids don't actually create a new physiological reaction.
They hijack it.
Exactly, they hijack a system you already have.
I was reading this section of the text, and it honestly blew my mind. Our bodies basically have a built-in pharmacy already operating.
We do. We have very specific protein receptors located on the membranes of cells in the central nervous system, as well as on nerve terminals in your gastrointestinal tract.
The gut, right?
Yeah, and these receptors are designated by Greek letters, primarily mu, kappa, and delta.
So these mu, kappa, and delta receptors aren't just sitting there empty, waiting for millions of years for someone to invent a synthetic painkiller in a lab. They exist for a reason.
Right. They exist to bind with your body's natural painkillers. These are endogenous peptide neurotransmitters, things like endorphins and enkephalins.
Okay, so like the endorphin rush you get from running.
Exactly. When you experience trauma or extreme stress, your body releases these natural peptides to bind to those receptors and, help you cope with the shock.
Which means when we take a synthetic opioid, or a natural opiate derived from a poppy plant like morphine, it's just mimicking what our own endorphins do. But I really want to understand the actual mechanics here. Like, how does a molecule binding to a receptor actually stop the feeling of pain? What is happening inside the cell?
The mechanism of action is completely fascinating. When an opioid binds to that receptor on a nerve cell, it essentially pulls two vital levers. First, it decreases the influx of calcium into the nerve ending.
And the texts mention calcium rushing in is what triggers the nerve to release pain-transmitting chemicals, right? Like glutamate.
Yes, glutamate and substance P. So by blocking the calcium, you're literally cutting off the transmission line. You are stopping the nerve from handing off the pain signal to the next nerve.
Oh, wow. Okay, and the second lever?
The second lever is increasing the flow of potassium out of the neuron. Pushing potassium out causes hyperpolarization. It essentially drains the battery of the nerve, making it incredibly difficult for the nerve to fire at all.
It's basically like a bouncer at a club.
I like that analogy. If the nerve cell is a noisy nightclub full of pain signals.
Right. The opioid receptor is the head bouncer. When activated, he's stopping new people from coming in. That's the blocking calcium part.
Exactly.
And simultaneously, he's kicking the rowdy people out the back door, flushing out the potassium. He essentially shuts down the party and clears the room.
Yeah.
The pain signals just hit a brick wall.
That paints the perfect picture of the cellular action. But looking at the bigger picture, this mechanism doesn't actually cure the source of your pain.
What do you mean?
Well, it alters your perception of it. The physical injury, the broken bone or the surgical incision is obviously still there. In fact, patients treated with a strong opioid like morphine are often completely aware that the pain is still present in their body.
Wait, I remember reading that and having to reread it. They still feel it. That sounds like it totally defeats the purpose.
They feel it, but the sensation is no longer unpleasant to them.
It is wild.
Yeah, the opioid alters the brain's emotional response to the signal. So if you've ever had your wisdom teeth out and took a prescription painkiller, you might have noticed that your jaw still throbbed. but you just didn't care anymore. The distress is just removed.
Which sounds like an absolute miracle of medicine. I mean, shutting down the pain nightclub and making the remaining sensation totally tolerable. So why do these drugs carry such massive risks?
Well, to figure that out, we have to look at the prototype. The standard by which literally every other opioid is judged.
Morphine.
Morphine. It is the major active drug contained in crude opium. It primarily binds to those MUT receptors we talked about, and when it enters your bloodstream, it triggers a physiological domino effect that touches almost every major system you have.
So it isn't just targeting the localized pain.
Not at all. It's doing a whole lot more.
Because the pharmacology texts highlight that morphine produces this powerful sense of contentment and well-being, that intense euphoria.
Yes, and that euphoria comes from the disinhibition of dopamine.
Disinhibition. Wait, so it's not that the opioid is creating dopamine directly?
No, it's not.
It's essentially taking the brain's brakes off. It inhibits the inhibitory neurons, allowing dopamine to just flood the system freely.
Exactly. That flood of dopamine is the intense high. But that peak comes with a profound, terrifying low. Morphine causes severe respiratory depression.
And reading through the overdose data, this is the fatal flaw, right? This is what actually kills people.
It is the absolute most common cause of death in acute opioid overdoses. Your brain has a built-in alarm system for breathing. Normally, when carbon dioxide builds up in your blood, your brain senses the rising acidity, hits the panic button, and forces your diaphragm to take a breath.
Right.
But morphine turns down the volume on that alarm. It reduces the sensitivity of your respiratory center to carbon dioxide. So eventually, the brain simply stops caring that CO2 is building up, and respiration just ceases entirely.
The texts also explain that tolerance to this specific effect develops really quickly. So if someone using morphine regularly over months needs higher and higher doses to get that pain relief.
And amazingly, their breathing adapts to survive those massive doses.
But if an opioid-naive person, say, someone who has literally never taken a painkiller before, takes that exact same high dose, their respiratory system just completely shuts down.
Yeah, that tolerance gap is incredibly dangerous. And the side effects cascade into other systems too. Morphine stimulates the release of histamine.
Oh, like an allergic reaction?
Exactly. That causes sweating, flushed skin, and most importantly, it can severely restrict the airways. Giving morphine to an asthmatic can trigger a major bronchoconstriction event.
It feels like a massive clinical detail for a doctor to navigate. And it also causes severe constipation, right? It essentially paralyzes the motility in the GI tract.
It does.
Which sounds awful for someone already recovering from surgery, but the texts note this side effect is actually used therapeutically in other contexts to treat severe diarrhea.
Yeah, medicine often repurposes a drug's side effect as a primary treatment. Another critical side effect stems from that respiratory depression. Because you are retaining carbon dioxide, the blood vessels in your brain actually dilate. And this increases cerebrospinal fluid pressure. Therefore, morphine is strictly off limits for individuals with severe head trauma or brain injuries. You just cannot afford to increase pressure inside a skull that is already injured or bleeding.
Wow. Okay, so it alters your breathing, paralyzes your gut, spikes your histamine levels, increases your brain pressure, and then there's the eyes. The texts spend a lot of time on meiosis, which is pinpoint pupils.
Right. Morphine excites a very specific nerve pathway called the oculomotor nerve. This sends a signal straight to the eye, causing the pupil to constrict down to an absolute pinpoint. And unlike the respiratory depression or the euphoria where the body builds tolerance over time, there is almost zero tolerance built to this pupil constriction.
That really stood out to me in the reading. If you see someone unconscious in an emergency room, the fact that a painkiller forces their eyes into pinpoints is just a wild evolutionary quirk.
But it serves as a crucial diagnostic clue for emergency responders. Many other causes of coma or respiratory failure, like head trauma or other drug toxicities, actually produce massive dilation of the pupil.
Oh, so they get huge instead of tiny.
Right. If a patient is comatose, barely breathing, and has pinpoint pupils, an opioid overdose is immediately the primary suspect, and treatment can begin instantly.
So, if morphine is this effective, but comes with all these dangerous side effects, why didn't scientists just stop there? Like, why did they keep creating new versions?
Clinical needs.
Because looking at the opioid family tree in these texts, it feels like an evolutionary arms race. Clinical needs demanded different tools, like the hunt for absolute speed, which brings us to fentanyl.
Yes, fentanyl. It was engineered to be an incredibly fast-acting, incredibly potent tool. It has roughly 100 times the analgesic potency of morphine.
100 times. That number is just staggering. How does a slight chemical tweak make it that much stronger?
It comes down to how the molecule travels. Fentanyl is highly lipolytic, which means it dissolves easily in fats.
Okay.
The cell membranes in your body, and specifically the blood-brain barrier, are essentially lipid layers. Because fentanyl is fat-soluble, it slips right through that barrier and enters the brain almost immediately.
So it bypasses the security.
Exactly. That gives it a rapid onset, but a very short duration of action, usually just 15 to 30 minutes when given intravenously.
Which perfectly explains the clinical application. The texts mention fentanyl is often used in transdermal patches for cancer patients.
Right.
If they are dealing with a sudden agonizing spike of what's called breakthrough pain, they need something that can penetrate the skin and get to the brain fast. They don't have 45 minutes to wait for a pill to digest.
And that fat solubility is highly sought after not just in hospitals, but in illicit drug use, which leads directly to heroin.
Right.
Heroin doesn't occur naturally. It's produced by chemically altering morphine. This modification leads to a threefold increase in potency over regular morphine.
I was reading the section on heroin's journey through the bloodstream, and it is fascinating. Heroin is essentially a Trojan horse.
Yes, that's exactly what it is.
Its extra lipid solubility allows it to crash through the blood-brain barrier much faster than morphine, which causes that exaggerated, intense rush of euphoria when someone injects it. But heroin itself isn't what your brain is reacting to long-term.
No, it's not.
Once it smuggles itself across the barrier into the brain, it unmasks itself.
It literally converts back into morphine once it is inside the central nervous system. The rapid delivery vehicle burns away, and the morphine binds to the mu receptors. It provides absolutely no unique medical benefit over morphine, but its rapid delivery makes it highly addictive, which is why it has no accepted medical use in the United States.
Then there are the weird exceptions in the family tree. The texts highlight meperidine as a major outlier.
Meperidine is a completely synthetic opioid. It binds to the exact same mu receptors, providing pain relief and causing respiratory depression.
But it breaks the primary diagnostic rule we just established, doesn't it?
It does. Meperidine does not cause pinpoint pupils. It actually causes the pupils to dilate because it has a totally different effect on the nervous system.
So if an ER doctor relies solely on the pinpoint pupil rule, they might completely miss a meperidine overdose.
Exactly.
And there's another huge danger with meperidine that the texts highlight, which is how it breaks down in the body.
When your liver processes meperidine, it creates a toxic byproduct. This metabolite has significant neurotoxic properties. If someone is taking large doses over time, this toxin accumulates in the body and can cause anxiety, severe tremors, muscle twitches, and even major seizures.
That's terrifying.
This accumulation is incredibly dangerous in elderly populations or anyone with failing kidneys who can't filter the toxin out. So it's strictly avoided for long-term pain management.
So we have fentanyl for speed, heroin is the Trojan horse, meperidine is the toxic exception, and then on the complete other end of the spectrum, the texts cover codeine.
Right, codeine.
It has about 30% the pain-killing potency of morphine. But it's not just a weak painkiller, it's essentially a precursor.
Codeine's ability to relieve pain entirely depends on your liver. When you take codeine, a very specific liver enzyme has to metabolize it and literally turn it into morphine. If it doesn't convert, it doesn't work.
Which means taking codeine is basically playing a genetic lottery. If you happen to be someone who genetically lacks enough that specific liver enzyme, you could take codeine and get absolutely zero pain relief.
Exactly, you get nothing.
But the texts do note it is excellent for suppressing coughs, even at doses that don't relieve pain.
Because the receptors in the brain that suppress the coughing reflex are entirely different from the receptors involved in pain analgesia. Codeine hits those cough receptors brilliantly without needing massive conversion.
Looking at this massive spectrum of drugs brings up a huge point about how they are actually administered. I always wondered, if these are so powerful, why aren't they all just given as a simple pill?
Pharmacology is heavily dictated by the route of administration. Taking a drug orally, like swallowing a morphine pill, is incredibly inefficient because of first-pass metabolism.
Right.
When you swallow a pill, it goes into your digestive tract and gets absorbed directly into the blood vessels leading straight to your liver. Your liver acts like a border patrol, metabolizing and destroying a massive portion of the drug before it ever has a chance to reach your brain or the rest of your body.
So to get a reliable massive effect, the drug has to bypass the liver initially. It has to avoid the border patrol, which is why clinical settings use intravenous injections or transdermal patches.
Bypassing that initial hepatic filter produces a massive predictable response. The drug goes straight to the brain.
Which also perfectly explains why abuse so often trends toward injections. You get 100% of the drug hitting the brain simultaneously.
Yes, all at once.
So, with drugs this powerful and a body that builds physical dependence rapidly, what happens when it goes wrong? How does modern medicine pull someone back from the brink of a fatal overdose or manage the agonizing process of addiction recovery? This brings us to the antidotes.
The emergency brake for an overdose is naloxone, commonly known as Narcan.
Narcan, right?
Naloxone is a competitive opioid antagonist. It binds with incredibly high affinity to those metareceptors we've been talking about, but it utterly fails to activate them.
Let's go back to our nightclub bouncer analogy. If the opioid is the bouncer shutting down the club, naloxone is like a massive brick wall suddenly built right in front of the door.
I love that. Yes, it forcefully kicks the opioid off the receptor and takes its place. If you have a patient who is comatose, turning blue, and not breathing from a fentanyl or heroin overdose, an injection of naloxone will rip the opioids off the receptors and reverse the respiratory depression within 30 to 60 seconds.
That fast.
Yes, the patient will wake up and start breathing almost instantly.
It's the ultimate high-stakes game of musical chairs. Naloxone runs into the nervous system, aggressively steals all the chairs from the opioid molecules, and just sits there. But there's a massive catch.
A very dangerous catch.
I was reading the pharmacokinetics here.
Yeah.
And naloxone has a very short half-life, only about 30 to 80 minutes. So naloxone steals all the chairs, saves the person's life, but then he gets bored and leaves the party early.
And that is the terrifying danger of naloxone. It wears off quickly. If the original opioid that caused the overdose, say a long-acting dose of morphine or a delayed-onset patch of fentanyl, is still circulating in the patient's bloodstream when the naloxone wears off, those opioid molecules will just sit right back down on the empty receptors.
Oh, wow.
The patient can lapse right back into a fatal coma without taking another dose.
You wake up, you think you're saved, but a ticking clock is running until the antidote burns away. That means you can never just hit someone with Narcan and leave them alone.
Never. Immediate and continued medical observation is mandatory. Now, that is the strategy for an acute, life-threatening overdose. Managing long-term addiction and withdrawal is a completely different pharmacological puzzle.
You definitely can't just send someone home with naloxone to cure their addiction. If an opioid abuser takes naloxone, it instantly rips all the opioids off the receptors, throwing them into immediate severe withdrawal.
Their body goes from a heavily medicated equilibrium to 0 in 30 seconds.
Right.
The shock to the system is brutal. To manage detoxification safely, medicine uses drugs like methadone and buprenorphine.
Let's look at methadone. It's a synthetic opioid. It's taken orally, and it binds to the same MAR receptors. A lot of people hear about methadone clinics and think, wait, aren't we just swapping an illegal addiction for a legal one?
It's a very common criticism, but looking at the pharmacology reveals why it's such a vital tool. Methadone is very lipophilic, meaning it accumulates heavily in the fat tissues of the body.
Okay.
Because it gets stored in the fat, it releases incredibly slowly into the bloodstream. This causes the drug's half-life to range anywhere from 12 to 40 hours, and it can even extend up to 150 hours.
150 hours. Compared to heroin, which crashes in just a few hours and leaves the body screaming for more.
Exactly. By substituting the rapid spikes of injected heroin with oral methadone, you induce far less euphoria, but you provide a massive, stable baseline of receptor activation.
Which prevents the withdrawal.
Yes, and opioid withdrawal is a horrifying autonomic storm. Severe anxiety, vomiting, muscle spasms, uncontrollable tremors.
Sounds like torture.
It is. When a patient is slowly weaned from methadone over months, the withdrawal syndrome is incredibly mild compared to the severe, unbearable shock of heroin withdrawal. It stretches the landing out, allowing the body to safely recalibrate without the massive euphoric spikes that drive the psychological craving.
And then there's buprenorphine, which the texts classify as a partial agonist.
Because it's a partial agonist, buprenorphine binds tightly to the receptor and acts like an opioid, but it has a built-in limit to its maximal effect. Most importantly, it exhibits a ceiling effect for respiratory depression.
A ceiling effect, meaning that no matter how much buprenorphine someone desperately takes, the respiratory depression will only drop so low.
Right.
It hits a floor, and won't cross the threshold into fatal respiratory arrest like heroin or fentanyl would.
Which makes it incredibly safe for office-based or outpatient detoxification.
Yeah.
A patient can take it at home without the constant fear of a lethal overdose, and it causes a much shorter duration of withdrawal symptoms compared to methadone.
We've covered a massive amount of ground today. We've seen how opioids, from the ancient poppy extracts of morphine to the highly engineered fat-soluble fentanyl patches, completely hijack our nervous system's internal pain management clutch.
It's a lot to process.
It really is. We've explored the domino effect of side effects, how turning off the pain also turns off the breathing alarms, tightens the pupils, and paralyzes the gut. And we've seen the incredible pharmacological game of tug-of-war used to save lives, using naloxone to competitively steal back those receptors, and methadone's long half-life to stretch out the agonizing clock of withdrawal.
The sheer complexity of these molecules is matched only by the complexity of the human nervous system they interact with.
Oh, absolutely.
Understanding the nuances like how codeine requires specific liver enzymes to unlock it, or how meperidine oddly dilates pupils instead of constricting them, highlights just how precise and delicate clinical pain management truly is.
The next time you read a headline about the opioid epidemic, or you just look at a post-surgery prescription bottle sitting on your counter, you now know the invisible cellular lock-and-key battles happening in the nervous system. You know the exact mechanics of the bouncer at the door of your nerve cells.
It provides a necessary perspective. You see both the clinical miracle of pain relief and the profound physiological danger of chemical dependence in the same breath.
It really does. But stepping back from all the dense pharmacology, it leaves me with one final lingering thought.
What's that?
Well, we learned today that our bodies naturally produce enkephalins and endorphins. These endogenous peptides bind these exact same opioid receptors to manage our own pain during trauma. It's a survival system already in place.
Right.
So if our brains are already hardwired with a built-in internal pharmacy specifically designed to reward us and soothe our physical trauma, when we use massive doses of synthetic opioids, are we inventing a new kind of high, or are we just hacking into our most primal evolutionary survival mechanism? Something to think about.